Hello. So Parkinson's disease is a really common disorder that you're going to encounter both in your general practice and on a neurology floor. It affects about 1% of Americans, so you should know this disease really well and how to treat it and also how to discern it from other diseases, which there are a lot that may look like Parkinson's disease. So, Parkinson's disease is a progressive neurodegenerative condition resulting in disorder of movement and oftentimes autonomic functioning, and in some instances, about 20 to 30% cognition, meaning that it will result in dementia. Like I mentioned, it affects about 1% of all Americans over the age of 60, and the incidence increases with age. So, this is not something that you see very much in young people. The average age of onset is 60, and it's very uncommon under the age of 40. It's also relatively uncommon under the age of 55. But like I said, as you get older, the incidence increases. There is a slight sex preponderance. The male to female ratio is 3 to 2. The etiology is unclear as far as what exactly is the precursor that stimulates the brain to degenerate and cause Parkinson's disease. But we do know the pathology with Parkinson's disease, and that's a degeneration of dopaminergic neurons that exist in the basal ganglia. And this particular part of the basal ganglia is called the substantia nigra. More specifically, the substantia nigra pars compacta. The other part is called the pars reticulata, but the substantia nigra pars compacta contains these dopaminergic neurons, which are ultimately responsible for activating movement. Remember that the basal ganglia is sort of our way to fine-tune our movement. We get our movement input from the motor cortex, but the basal ganglia is what allows us to make fine motor skills like writing or sewing or buttoning your shirt up. You need to be able to have fine control over your movement, and it's the basal ganglia that is able to tell your nerves that you don't want to make this motion, you want to make that motion. So it's sort of the fine refiner, the editor of the input that you're getting from the motor cortex. So if you lose that, then you're going to have an effect on your movement. And here we're losing dopaminergic neurons that are responsible for activating movement. So the result then, if you lose that, is that you're going to have less movement. And so one of the cardinal signs of Parkinson's disease is bradykinesia. Some of the other signs that you see in Parkinson's disease include resting tremor, rigidity, and postural instability. So the onset of Parkinson's disease is often asymmetric. So a lot of times a patient will be able to relate to you a certain onset. They noticed it maybe in their thumb or in their fingers or in their foot first, where they had this sort of tremor, and eventually it starts spreading to other parts of the body in usually a pretty unpredictable way. A lot of patients will report having had restlessness during sleep or sleepwalking, but sometimes and oftentimes it's going to be the patient's wife or husband that is going to report that to you. So that's definitely something that you should be asking for, because a lot of patients, I would even say the majority of patients with Parkinson's disease, do have restlessness during sleep. Some patients will notice a reduction in their sense of smell, but sometimes sometimes the loss of smell is so gradual that patients don't notice it themselves. But if you ask the patient, have you noticed a reduction in your sense of smell, some of them may say yes, and that's definitely something that you would notice. So these are all some things that you should look for in the patient's history. As far as symptoms, the most common thing, the one thing that really stands out is this resting tremor. And it looks like a pill rolling tremor. if you can imagine rolling a little ball of like dough, or rolling a marble in your hand. That's basically what it looks like. So they call it a pill rolling tremor because back in the day they used to roll pills, and that's how they made pills. So it's a pill rolling tremor, and all it is it's basically if you have a clenched fist, you'd see the thumb kind of moving around. You also see a reduction in dexterity. A lot of times it's enough to affect some of the activities of daily life, so like writing or sewing, if the patient does that, or buttoning up their shirt. Bradykinesia may be noticed, particularly by family members. They may say that the patient is walking slower, or that when they're eating, they're bringing their fork up to their mouth a lot slower. Everything they're doing seems like slow motion. Masked faces is another thing that we see that's related to bradykinesia, and all that is reduced facial expression. Other things that you can see as mentioned are sleep disturbances. You can see autonomic dysfunction, which could include constipation, sweating, sexual dysfunction. Bradyphrenia is a reduction of cognition, not so much dementia, but you can't think as clearly, you can't think as quickly. And then dementia is something that is usually seen in more advanced Parkinson's disease. On physical exam, you'd see the resting tremor, which you may even just see that looking at the patient. You don't necessarily have to do anything to elicit that. There's a cogwheel rigidity that's really commonly noted, and cogwheel rigidity is just this sort of relenting and increasing rigidity at the wrist as you try to move the wrist in a circular motion. You may see signs reflective of bradykinesia, so decreased speed of repetitive movements. If you tell them to tap their pointer finger to their thumb on the same hand and tap it as quickly as they can, you'd probably notice a decrease in speed of that. If you look at yourself, how quickly you can do that, you would know that if they're doing it quite slowly, you would notice a big difference. Micrographia, so that can be noted if you have the patient give a writing sample. A lot of times, though, it's going to be useful to have the significant other, or the daughter or the caretaker or whomever knows the patient, to be able to say this is different than how they were a year ago or 3 years ago. Again, masked faces, and then sometimes you can see you would notice a soft or quiet voice, which is often accompanied by poor articulation, just because they're not as able to move those facial muscles as prominently as they were able to, and that just has to do with the bradykinesia. When you're doing the physical exam, a lot of times if you ask them to speak louder, that poor articulation goes away because they're putting more input into those muscles. And then the common fenestrating gait is more common in more advanced Parkinson's disease, but that's just less lifting of the foot and sort of dragging of the feet. A lot of times the patient will be hunched over. So it's kind of like a lazy walk. How do we diagnose Parkinson's disease? Well, it is a clinical diagnosis, but like most clinical diagnoses, other causes should be excluded. And by other causes, I mean other causes of Parkinsonian symptoms. So you can have Parkinsonian symptoms, but not have Parkinson's disease. So those causes should be excluded, at least clinically. Now for Parkinson's disease, if they have a very typical presentation, as I mentioned with the previous symptoms and physical exam, then lab tests and imaging are not needed. However, there are some instances where they are needed. So if the patient is presenting with symptoms consistent with Parkinson's disease and they're younger than 55, or if they have additional symptoms that are not associated with Parkinson's disease, such as vertical gaze palsy, then you should do neuroimaging. CT probably to start with, and then MRI would be more accurate. That's usually how it goes for the USMLE, although a lot of neurologists and standard practice would just go straight to an MRI. So those are the indications if the patient presents with Parkinson's disease to do neuroimaging. But most of the time, the presentation is typical, very stereotypic, and you're not going to need to get lab tests or imaging. What are the criteria for the clinical diagnosis of Parkinson's disease? Well, remember those four cardinal symptoms that I told you about: resting tremor, rigidity, bradykinesia, and postural instability. The first three generally show up early on in the disease. So resting tremor, rigidity, and bradykinesia. If the patient has two or more of those and it's not explained by any other condition, then the patient has Parkinson's disease. Postural instability, they don't need to have at first. That's usually more associated with more advanced disease. What is the differential for Parkinson's disease? So this is important to know the differential because there are a lot of diseases that look Parkinsonian, but they're not Parkinson's disease. So there are the so-called Parkinson plus syndromes. The three really important ones to know about this, in my opinion, for the USMLE are Shy-Drager syndrome, progressive supranuclear palsy, and Lewy body dementia. We talked about Lewy body dementia in the dementia section. Shy-Drager syndrome and progressive supranuclear palsy I'll talk about in a few more slides. Normal pressure hydrocephalus, this is the wet, wobbly, and wacky condition. All it is a hydrocephalus, but you have a normal pressure, a normal intracranial pressure. So what you should do in this case, I should mention, wet means urinary continence, wobbly means gait disturbances, and wacky means a certain level of dementia. So what you should do in this case, particularly if the patient is young and especially if they have urinary incontinence. Urinary incontinence is never associated with Parkinson's disease. You should definitely go ahead right away and get a CT. A CT should be good enough for normal pressure hydrocephalus because all you're looking for is dilated ventricles. If the patient has dilated ventricles and these wet, wobbly, and wacky symptoms, then the presumptive diagnosis is normal pressure hydrocephalus, and you can go about treating that by draining off about 20 milliliters of cerebrospinal fluid, and you would notice that the symptoms would resolve. And at that point, then you could make the diagnosis of normal pressure hydrocephalus because of the response. Essential tremor is very, very, very common. It tends to go in families, and essential tremor is all it really says, just essential tremor. It's tremor only, no other symptoms. It usually resolves with alcohol consumption. That's not to say that you're going to tell the patient to drink alcohol to make their essential tremor go away, but if you ask the patient, does drinking alcohol make your tremor go away or make it less severe? If they say yes, then that points you towards essential tremor. The medication of choice for essential tremor is propranolol, which is a beta blocker. Now, when we're talking about essential tremor, a lot of this happens in younger patients. So if you have a younger patient who presents with a tremor, most of the time it's going to be essential tremor. Huntington's disease, you usually know because it's an autosomal dominant disorder. It follows in families. The patient's mom or dad will have had it, or they may report their aunts or uncles or their grandparents have had it. And what you first notice in Huntington's disease is personality changes and anhedonia. And then you'll also see things that you definitely don't see in Parkinson's disease, which are bulismus and chorea. And Huntington's disease is a degradation of the caudate. And like I said, it's autosomal dominant, so it follows in families very particularly. The way we diagnose that is with genetic testing of chromosome 4. Wilson's disease also tends to follow in families. What you'll notice here is, again, this tends to happen in younger patients. You'll notice quite profound psychiatric disturbances, often including psychosis. What also happens in Wilson's disease is that you get liver failure. Wilson's disease is a disorder of copper metabolism, and copper is toxic to the liver if it's in elevated amounts. So you wind up getting liver failure, or you may even present with actual hepatocellular carcinoma. So liver failure is what really separates Wilson's disease out from the others. You may see Kaiser-Fleischer rings on the patient, and Kaiser-Fleischer rings are just deposition of copper around the peripheral part of the iris. So you'd be able to see it. A lot of times you can see it just by looking at the patient. Sometimes you may need to use an ophthalmologic tool to observe it. Post-encephalitic Parkinsonism, I guess the only way to know this from the others is that the patient has had recent encephalitis. So if you have a patient who has had encephalitis within the past month or two, and now they have Parkinsonian symptoms, it's more than likely post-encephalitic Parkinsonism. And then finally, if you watched the psychiatry lectures and you know what some of the antipsychotic drugs do, remember antipsychotics, both the atypical and the typical, are dopamine antagonists. And what is Parkinson's disease? It's a disorder of the dopaminergic neurons. So basically you're simulating Parkinson's disease when you're taking neuroleptics to a certain degree. Overall, as a patient has taken neuroleptics for a long period of times, especially the typical, the old-fashioned neuroleptics like Haldol, they can develop Parkinsonian symptoms, and they are permanent. How do we treat Parkinson's disease? The gold standard of therapy in Parkinson's disease is levodopa-carbidopa. Now, we use both of those in conjunction in the same pill because levodopa, which is the dopamine, remember that dopamine cannot cross the blood barrier itself. So we use levodopa, which is a dopamine precursor, but unfortunately in the blood, levodopa would be quickly converted into dopamine, and then that's useless because that can't cross into the brain. So we use carbidopa to inhibit that process. So when you add carbidopa to levodopa, the levodopa can make it to the blood-brain barrier, and then it can be converted into dopamine in the brain. So levodopa, carbidopa, that's the gold standard of therapy in Parkinson's disease. However, we usually like to tailor our therapy towards the individual patient. So we don't necessarily jump right to levodopa, carbidopa if the patient is at a higher functioning status. So some medical therapies include, as mentioned, levodopa, carbidopa, anticholinergics, which tend to be used in patients of a higher functioning status who are younger. That includes pramipexole, ropinirole, and bromocriptine. There was a previous drug that was used that was withdrawn from the market, but these are the only three drugs that are used now. Amantadine is another drug that's used usually in older patients who are of higher functioning status. COMT inhibitors are used to reduce some of the adverse effects of the dopamine agonists and levodopa-carbidopa. And MAOB inhibitors like selegiline and rasagiline are useful for patients who are not responding to the dopamine agonists or levodopa-carbidopa, which tends to happen later on in the therapy. The brain will stop responding to these drugs. Okay. I should add that bromocriptine is an ergot-based drug, and so it can result in some cardiac toxicity. So I would use that with caution. The other drug that used to be used was actually found to cause valvular damage, and so it was withdrawn from the market about, I think, 6 or 7 years ago. All right, when do we use which drugs? So as I mentioned, if the patient is higher functioning, then we should try to hold off the levodopa-carbidopa. And the reason is because you're only going to respond to the dopamine drugs for so long, and then you won't respond to them, and ultimately then you start to deteriorate. These drugs only prolong your survival, prolong the your symptomless days. So you want to try to put off using levodopa carbidopa as long as you can. So if the patient's higher functioning, if they can manage their activities of daily life, and they don't have significant postural instability, which can be dangerous, then the dopaminergics can be withheld temporarily because they will ultimately need them, because the disease will progress and the patient can be started on another agent. So how do we choose what agent? If the patient is under the age of 60, we can go ahead and use an anticholinergic, which is slightly more effective than amantadine. And the anticholinergics of choice would be trihexyphenidyl or benztropine. We do not like to use anticholinergics in the elderly because of the side effects, some of which include postural hypotension, which can result in falls, and falls in older people can be all sorts of surgical problems, which we don't want to deal with. So for patients over the age of 60, the treatment of choice is amantadine. Now, if the patient is lower functioning, if their activities of daily life are significantly affected, or if they have really significant postural instability, usually the patients with really severe gait problems, then we're going to start them on the dopaminergics. We'd also start patients on dopaminergics if they're not responding to previous therapy, being the anticholinergic or amantadine. So we start them with levodopa and carbidopa, and that's going to be for all patients. And then for an increased effect, after we've started levodopa carbidopa, if we still haven't gotten the effect we want, we can add on a dopamine agonist, and that would be pramipexole or ropinirole, or for that matter, bromocriptine. So managing adverse effects. The major adverse effects of the dopaminergic drugs, just think, what would we see in a patient that has an elevated level of dopamine? We would see abnormal movements. Remember, we are giving dopamine to the patient. So what we're doing is we're stimulating their basal ganglia. Once you stimulate the patient's basal ganglia, they're going to have the opposite symptoms of Parkinson's disease. It's really hard to get the perfect balance. So if you go too far in the other way, you'd have the adverse effects of the opposite of Parkinson's, which would be abnormal movements, which is termed dyskinesia, akathisia, which would be restlessness, and then nausea can be another really common adverse effect of dopaminergic drugs. And then another problem with the dopaminergic drugs is that their levels in the blood tend to fluctuate, and so you can get response fluctuation throughout the day, and that can be really problematic for a lot of patients. They can go from dyskinesia and akathisia back to bradykinesia and then back to dyskinesia several times throughout the week or even the day. So it can be really helpful to do as best we can to keep that level, that fluctuation, to a minimum. So the drug we use to keep their level keep their drug level or reduce their response fluctuation, sort of to keep it level throughout the day, would be the COMT inhibitors, which were mentioned earlier. Those tend to reduce fluctuations and adverse effects, and those are entacapone and tolcapone. And these drugs are never used by themselves. They don't do anything to help the Parkinsonian symptoms. All they do is they help regulate the dopaminergic drug level in the blood, so that you're not having highs and lows all the time on your dopaminergic drugs. So these can be useful for patients that are having these response fluctuations. If they have nausea, that can be effectively managed with domperidone. That tends to be the drug of choice for managing nausea in patients with Parkinson's. Remember, some of the other nausea medications are anticholinergics or antihistamines. Those aren't recommended. And then if the patient's response to the dopaminergic starts to decline, which eventually it will, some of the MAO-B inhibitors can be used, and the two that are used most commonly are selegiline and rasagiline. But these drugs should not be used as a primary therapy. The primary therapy for managing Parkinson's disease, if they do have a reduction in function, would be levodopa, carbidopa, and the dopamine agonists. Selegiline and rasagiline should only be used once they've stopped responding to levodopa, carbidopa, and the dopamine agonists. Outpatient management should include regular follow-up with a primary care physician and referral to neurology. They're probably going to be seeing a neurologist on a regular basis, and it's more than likely going to be the neurologist that manages their Parkinson's disease, unless you're practicing in a rural area. It is certainly possible and likely that you as a primary care physician may be managing their Parkinson's. You should always screen for depression and other mood disorders. These tend to have a higher frequency in patients with Parkinson's disease. There also tends to be a higher frequency of psychosis. Remember, we're using dopamine agonists, and what do we use to treat schizophrenia? We use dopamine antagonists. There's a dopamine theory in schizophrenia. So if we're flooding the patient with dopamine, we can actually induce like a schizophrenic state. So you may have adverse effects from the dopamine drugs that include psychiatric effects like psychosis. So if the patient does go into psychosis, the drug of choice to treat their psychosis is quetiapine or Seroquel. And that is the one drug that's recommended more than any antipsychotic because it tends to have the least effect on the movement symptoms of Parkinson's disease. Remember, the antipsychotics are dopamine antagonists, so we got to be really careful about using these in a patient who's already suffering from a disease that's destroying their dopaminergic neurons. And then finally, exercise and speech therapy can improve their quality of life. That just goes without saying because a lot of patients with Parkinson's have difficult with movement and they have difficult with speaking, and that can make them suffer in social situations and make them want to stay in the house, which can be problematic for them. Okay, so how about these Parkinson's plus syndromes? You got to be really aware of these for the USMLE because the USMLE likes to throw curveballs, and some of those curveballs can be with Parkinsonian symptoms. They're going to give you patients who have these symptoms that are consistent with Parkinson's disease, and they may throw in Parkinson's disease as the diagnosis, the most likely diagnosis. But with the Parkinson's plus syndrome, as its name implies, it's going to be Parkinson's syndrome plus another disease, another symptom that doesn't occur with Parkinson's syndrome. So, progressive supranuclear palsy is perhaps the most common Parkinson's plus syndrome, and all it is Parkinsonian symptoms plus vertical gaze palsy. How you treat these Parkinson's plus syndrome is beyond the scope of the USMLE, so I just want you to be able to recognize these. So with progressive supranuclear palsy, you're going to see ocular symptoms, and it will tend to be a vertical gaze palsy. So they're going to have difficulty moving their eyes upward or downwards. And the tremor of Parkinson's disease may not be as prominent in these patients. Shy-Drager syndrome, also known as multiple system atrophy, would be your Parkinsonian symptoms plus a really, really severe and pronounced autonomic instability and cerebellar signs, which could include gait issues and nystagmus. You can have autonomic instability in Parkinson's disease itself, but if you're having really, really severe autonomic instability and really, really severe gait issues beyond what you would expect with Parkinson's disease, then you should consider Shy-Drager syndrome. So another thing you can see in Shy-Drager syndrome includes upper motor neuron signs, and that's just because you're having a degeneration of more than just the substantia nigra. It's also including the upper motor neurons. So you would also see hyperreflexia and primitive reflexes, which you would not see in Parkinson's syndrome alone. The cerebellar symptoms that you would see would include nystagmus. So what you should do if you're suspecting Shy-Drager syndrome is get imaging. A lot of times with Shy-Drager syndrome, you're going to see atrophy of the brainstem and of the cerebellum, and that is not something that you would see in Parkinson's plus syndrome, not something you would see in Parkinson's syndrome itself. And then finally, Lewy body dementia. We talked about this in the dementia section. Remember, patients with Parkinson's disease can get dementia, but the patients who have Lewy body dementia have Parkinsonian symptoms along with dementia coinciding with the onset of their symptoms, or right around the onset of their symptoms. Patients with Parkinson's disease, not Lewy body dementia, but Parkinson's disease, they do develop a dementia that involves Lewy bodies, but it's not Lewy body dementia. It's Parkinson's dementia, because they were diagnosed with Parkinson's disease, and they had Parkinson's disease for some time, and they did not have dementia, but then they developed the dementia later on. That's Parkinson's dementia. Lewy body dementia is Parkinsonian symptoms that coincide roughly with the dementia. So important to tease the two of those apart. They can be somewhat confused. If you have any questions, let me know.